Hi everyone. My telehealth program focuses around remote monitoring and some live video telehealth uh, encounters in a care management capacity. So this would be remote monitoring of at first Medicare patients with two or more chronic conditions, so things such as diabetes, hypertension, cardiovascular disease, others. Managing these patients outside of the primary care setting to hopefully reduce things like hospital admissions and readmissions, particularly readmissions within 30 days, which can be particularly detrimental to hospitals. There's up to a 3% annual penalty um, on all Medicare DRG billings for hospitals that have too many 30-day readmissions. Also, reducing utilization of the emergency department when it is not necessary, when the patient can be controlled in another setting of care or remotely and via telehealth. So this would be a program staffed primarily with nurse case managers, pharmacists, health coaches, dietitians, social workers, clinical social workers, all really aimed at helping to manage patients' illnesses outside of that doctor's office. This can also have effects in lowering provider burnout due to a less packed schedule, having less primary care visits, being able to manage those patients outside of the office, providers then having more time for more complex cases in the office, and perhaps freeing up schedule slots to improve patient access. Um, so these are a lot of the business model, the financial case for the program is savings in readmissions, unnecessary ED utilization, um, savings in unnecessary primary care visits that can be dealt with at a lower cost by telehealth or remote monitoring. There's also potential savings in value-based programs. So these are alternative payment models, mostly coming from CMS, from Medicare. Um, a big one right now is Comprehensive Primary Care Plus, or CPC Plus, and it's uh, the next iteration of the CPC Plus model, which is called Primary Care First, or PCF. Um, Medicare Shared Savings Program is another one of these, although I do not directly manage that program. I have a little more knowledge of CPC Plus and PCF. So within these programs, part of the payment model is based upon utilization, specifically acute hospital inpatient stays, and also ED utilization, and also upon patient outcomes, so outcomes along chronic disease. So a lot of the monetary reimbursement model of these programs revolves around these. So if my telehealth program that I'm proposing can also kind of feed into these programs, reducing utilization, keeping costs down, improving health outcomes and quality measures, and then that can generate more revenue or more savings within these programs that can be in turn fed back into the program to kind of be self-sustaining. One of the probably the biggest drawback of this is there's an inherent instability in the Medicare alternative payment models. It's still relatively very much in the infancy of Medicare really developing these alternative payment models, moving away from the complete fee for service world and more into fee for quality, fee for performance, fee for health outcomes. So these are still in their infancy, these programs, and there's a degree of instability. The programs can change significantly from one year to the next in terms of payment models or regulations. And also, some of the programs are pilots that last for a couple of years and then drop off or are replaced with another program that Medicare believes is more viable. So there's some instability in terms of those programs and the funding. However, there are other sources of funding, including perhaps having agreements with hospital partners to share savings on readmissions and decreasing ED utilization. Um, there's also direct billing, so we can do some of the CPT codes for remote monitoring and basically care management of patients outside of the doctor's office. Those can be directly billed in most circumstances, as long as you're meeting all the regulations, and those can create another revenue stream for the program to kind of push up against some of that instability of the CMS alternative payment models. Thank you.